Good morning, Maxime. Can you hear me?
Good morning. Thank
Okay,
you.
excellent.
Excellent.
How are you doing?
Great. Good. You? How are you?
Busy.
Oh,
It's been
okay.
trade time.
All right. Good to know.
And only with administrative work, unfortunately. No,
Wait, sorry.
only with administrative work, not the fun stuff.
Of course.
It's been.
I'm sure it's a lot.
We had an outbreak at the Western, at our hospital.
Oh.
And now we are no longer allowed to actually enter the hospital. They need to do a deep cleaning today. So the entire Western is out of, for the first time ever, we can't accept any cases. And then quite a few like healthcare workers got it. So complete lockdown. Feels weird.
I don't know what it's. I mean, I wonder if they ever look on the surfaces of these places like this. We have hundreds of patients. Of course, can't imagine. Hey, Tom, good morning.
Hello.
Hi.
Good morning.
Good morning.
Right, we got a few more minutes.
Okay. You want to give me the share screen in the meantime?
Yeah, sure. I can share my screen.
One second. One second. Okay, Ethan, you got it. Can you do it now?
Yeah. Yeah, I can. Hold on.
Very good.
What do you see? Do you see just the
I see the show. I just see I see that.
slideshow or the?
No, just a slideshow, nothing else. I don't see anything on the side, so it's great.
Okay, good.
Okay.
Oh, sorry, I just
Go
stopped.
away. In the meantime, thank you everybody for joining. We'll start in just a few minutes. Hi, Kitty Pong. If you are new to the Zoom platform, please mute yourself unless you want to speak. If you have a question, of course, you could either go to the chat function or you could, just say something. If you're not saying, if you're not speaking, please mute so that we minimize the background noise. The idea is that everybody can participate. It's not like a webinar where you have to raise your hand. You can speak anytime. Just if you're not, please go on mute. We're just waiting for a few minutes to start. We start at 8 sharp. We have a busy program. Bendorf, good morning. I see you there. Thank you for joining. We're just waiting for a little bit. Let me see where we stand.
Maxime,
Yes,
can you hear me?
yes, I can.
Are all the participants going to show up here on the right side, or is it only the people that present stuff here? Or how is this going to work?
You can see everybody. So there's 61 people currently on.
I
And
see.
more
Okay.
people are coming in. So everybody, you can see everybody, and this is for everyone. Everyone can either raise your hand or there's a chat function. If you're new to the Zoom, go to chat, ask a question or whatever, comment, anything. You can chat, you could speak up. If you're not talking, please mute the mic so that background noise is not filtering in.
Mhm.
Yeah, you could this is totally participatory. Anyway, it's 8 o'clock. We're going to start. I'm sure more people are going to join in. So thank you everybody for coming to the BANANAZ. We're going to start in a minute. We have a packed program. We have some amazing, superb guest lecturers today, in addition to the regular cast. Bendorf, Goetz, Timo Krings. If you don't, if you're not familiar with our small world, if you are not sure who they are, you could please look them up, look up their bibliographies. We have just a tremendous depth of expertise here today. Cavernous sinus is an extremely strategic structure for many vascular and non-vascular reasons, as I'm sure many of you know, and it's a great topic. So anyway, so the plan today is Eitan Raz is going to start with a lecture, and then we'll open it up to Timo Bendorf cases, anything, but just to follow up, and it's gonna, we're gonna dive more into it. If you have any questions, again, there's the chat where you could speak up. All right, Eitan, you're on.
Thank you. Thank you for the introduction. So I will talk today about the cavernous sinus. Now this is the outline. I will not start with the embryology. I will start with the classic cavernous sinus anatomy, followed by the vascular angiographic anatomy a little more in detail, talking a little about the longitudinal axis concept, and the compartments, the discussion about the compartment and how that develops histologically. And then with some more attention about the variant paracellular sinus outflow. And there, at that point, we will talk about some embryological considerations. And then I will end up talking about the venous plexus of Reitert. So, the cavernous sinus, what makes it a unique structure? This is more like a classical radiological coronal view. While this on the right is more like how the surgeon will look at it. What makes it a unique structure is certainly the fact that it is a vein which contains also other structures, such as the artery and the nerves. Now, indeed, it's a structure which is 3 by 2 centimeters, located between the sella and the Meckel's cave. And as we said, contain nerves. In particular, in detail, it contains the 3rd, 4th, 5th, and 6th nerves, as well as the internal carotid artery. When we look at the nerves, how their relationship compared to the sinus itself, 3, 4, and 5 are more like on the side, while the 6th nerve is usually runs in the middle of it. Now, the cavernous sinus is connected to quite a few other veins, and is connected to the ophthalmic vein, and I'm using this graph from neuroangio.org here. Ophthalmic vein, intercavernous sinus is connected with the other cavernous sinus, with the sylvian vein in some ways that we will go into the details about. It's connected to the Petrosal sinus, the superior and the inferior Petrosal sinus. It's connected with the pterygopalatine plexus via the foramen ovale, with the clival plexus, and in some other ways is connected also to the Rosenthal vein or the uncal vein or some other cortical veins. So this is a classic view, lateral view, venous phase of an ICA injection. And this is the front, this is the back. And what you see here in this region is the cavernous sinus. Now, as you see with the arrows, there seems like to be a shadow of something there. And the shadow, what we see there is essentially like the carotid artery shadow, all right? And so the best way to really like is put in relationship the vein structure with the internal carotid artery is by doing what we call it a double masking. So essentially you mask the arterial phase within the venous phase. And in this way, you can really appreciate very well the relationship between the two. You can do it in the sagittal plane, in the lateral view, frontal view. They're very helpful. Now, this instead is another amazing way to understand the anatomy of the cavernous sinus. What you're seeing here are two images, a subtracted view on the left, an unsubtracted view on the right of the same image, obtained from an inferior petrosal sinus sampling. And you see here there are two catheters into both inferior petrosal sinuses, and the injection is done simultaneously by injection of both catheters together. And by doing this injection, you can really appreciate a lot the anatomy here. We can see like the shadow again, the shadow of the ICA on both sides. In this case is taken from the front. And here we can recognize other things. For example, here, this is the shadow of the sixth nerve, which runs within the sinus itself, and so forth. These images really make us, give us some possibility to understand this anatomy very well. So let me go through this. This is like the same patient, like from frontal view. Again, we see here the internal carotid artery, and we can compare on the same patient with the MRI, and we see how the ICA, which we see very well on this T2 and T1 post-contrast, really like this is where it would run along the cavernous, before the cavernous sinus. So we see the relationship, its relationship with the inferior petrosal sinus and so forth. This is like the same thing, but on the lateral view. So what we see here, this is the ICA, okay? This is the sagittal T1, this is the ICA. And here we see very well the relationship here with the Meckel's cave, which appears as a non-opacified structure on the lateral view of the same thing. Again, injection through the inferior petrosal sinus, this is the catheter inside, injection, and we see the filling of the cavernous sinus with all its venous connections. So this is what we can do also. We can do like some dyna CTs. We get like source data. We can reconstruct them in many ways. Thank you to my colleague, Dr. Young, who like loves to create amazing cinematic rendering of these pictures. Once you have the source data, you can do many things. We will go to the details of this anatomy, but this is just a beautiful appearing posterior cavernous sinus. So in this case, in this injection, for example, we didn't have to get to fill the whole part of the cavernous sinus, but good enough. So let's start with some of the connections. And here we have a good view. This is a lateral view, again, that shows very well the connection with the ophthalmic vein. Again, that's where the catheter is, the injection is done. It's an injection that has to be a little hard to overcome all the venous inflow from the other structures. But this shows very well like the connection with the ophthalmic vein, the superior ophthalmic vein, the inferior ophthalmic vein that joins into a single trunk here and joins the anterior part of the cavernous sinus. Now, other ways to see the ophthalmic veins, for example, you have it in this picture. I don't know if, what you see in this picture is a very interesting thing. So this is a subtracted image, unsubtracted image of the same phase, and you have you see veins everywhere here, right? Like veins everywhere, as Dodi likes to say. I don't know if he's connected. Veins, but we know veins are everywhere. So essentially, what kind of injection is done here? You see a catheter here. This is actually a neuron max, which is located into a superficial temporal vein. And this patient has a scalp AVM. Somebody is annotating there, but it's okay. This is a scalp AVM, And we are essentially doing an access for a transvenous embolization of the scalp vein. But once we're in this vein and we inject hard enough, like we overcome all the other venous outflow of the AVM. And what is interesting on this image is, if you see here, you see like this vein going to the front of the head, okay, connecting with the supraophthalmic vein. And here it is the connection with the ophthalmic vein that goes posteriorly. And then it joins here, the cavernous sinus. So we're seeing the cavernous sinus from a scalp vein injection. Remindful of this connection that there is between the cavernous sinus, the ophthalmic vein, and the veins of the scalp. So cavernous sinus filling from the scalp. This is the same image. Max, there's all this annotation on the screen. Do you see them? Can you remove them? Somebody annotated the screen, and I'm not sure if how to remove it. All right. Yeah, this is better. Okay, so this is same thing, you know, just to remind, if you have the anaglyph glasses, like we like sometimes to show some of these images, which for those who are still training to stereo cross eye stereos, this can be another way to understand the 3D, to look at 3D. Now back to the ophthalmic vein. So we showed how the ophthalmic vein are connected to the cavernous sinus. We see the ophthalmic vein enlarged very often in the situation of disease, such as this one. This is a classic case in which you see an extremely large superior ophthalmic vein. You see also an enlarged cavernous sinus, and this is like a classic situation of direct carotid cavernous fistula, traumatic, right? And there's so much high flow that there's such an enlargement of the superior ophthalmic vein. This is a classic example. So ophthalmic vein enlarged because of this condition. Then I have to remind, there's other condition that can lead to enlargement of the ophthalmic vein. This is a rare case, but it still can happen, and we have to be mindful about it. We see bilateral enlarged ophthalmic vein. Now, when we do a T1 post-contrast, we confirm this. These are both are very enlarged, but the reason of this, and I have much more to document this, but this is not the purpose of this talk. The purpose is to show how the reason of an enlargement of the ophthalmic vein can indeed be an anatomical variant. And in this case, the problem is that there is there's a very hypoplastic, atretic, and superior sagittal sinus with all sort of variant, venous variant, including like venous outflow preferentially across the superior ophthalmic veins. So superior ophthalmic vein enlarged as a part of a variant. Or cases like this, it's a sad case. You see this CT, it's obvious that both superior ophthalmic vein are enlarged. Why are enlarged? This is a 57-year-old patient in the ICU, COVID positive, cardiac arrest, hypoxic ischemic encephalopathy. Brain is full, intracranial hypertension. And intracranial hypertension, one of the ways that it manifests is with increased outflow through the superior ophthalmic vein and then gets enlarged. So superior ophthalmic vein enlargement as in setting of intracranial hypertension. For this other case, I'll go very fast here, but very interesting. You see an abnormal superior ophthalmic vein on one side, confirmed on the axial T2. On T1, it's filling. What's going on here? There's certainly something abnormal. Something is asymmetric. And then you go back and look at the post-contrast T1 and you observe that there is indeed a lesion. There is a lesion in the anterior aspect of the cavernous sinus. That lesion causes some stagnation and some slow flow in the superior ophthalmic vein. And this is another example of pathology that can involve that. So moving forward to other connection, the superficial middle cerebral vein, also known as the Sylvian vein. This is another connection with the cavernous sinus. This is more like a normal appearance. Very commonly, you see a little superficial middle cerebral vein going back here and kind of trying to find a connection with the cavernous sinus. Now, there's all sort of variant that we will go through a little later in this talk about the connection between these and the cavernous sinus. But here on the right, I want to show you like really like a pathological example in which you see that connection in reverse. It's the same case as before. The interesting thing is that with this direct carotid cavernous fistula, yes, you see most of the outflow going anteriorly toward the superior ophthalmic vein, but look at this. Look at all these vessels. What are those? Those are just expression of this connection between the cavernous sinus and the superficial middle cerebral vein, because these are all veins that are engorged and filling like the flow from the fistula itself. Some of them then find some other outflow through some cortical vein to the superior sagittal sinus here, more anteriorly. But by looking at these images, it's just like let you understand this connection between the cavernous sinus and the superficial and the middle cerebral veins. Now, going back to that case, like again, we went through this. The reason what we see here on flare, both here on the anterior temporal pole and here more like on the lateral frontal parietal lobes, is like this abnormal signal. What is this? This is like more or less related to the congestion that we appreciate actually very well on this T1. You see all these increased veins. Okay, we have a correlate on the angiogram, and here you see like the venous congestion, venous edema within the same structure, which in this particular patient caused very bad seizures. So, and again, like the angiographical correlate of that is that you see like filling of this superficial middle cerebral vein with stagnation. So, superficial middle cerebral vein, like there's quite many variants. And here I'll show you 4 different examples, okay? And here you have a superficial middle cerebral vein going along the middle cranial fossa and then joining here the anterior part of the cavernous sinus. There's a lot of debate about where the superficial middle cerebral vein, if it joins what is called the sphenoparietal sinus, does the sphenoparietal sinus exist or not, and so forth. The concept is that it eventually joins the cavernous sinus. If it joins through like a connection with other meningeal vein, it seems like it's not really like the most accepted theory as of now, but it's accepted that eventually it drains and joins the anterior part of the cavernous sinus most of the time. Now there's other variants like this one in which it goes like more laterally. It's called like a squamosal variant, goes lateral. This is a lateral part of it, okay, goes lateral, and then in this case it joins the superior Petrosal sinus, while maybe a little part of it, like a separate channel, little part joins here the anterior part of the cavernous sinus. Here it goes like along the inferior, along the floor of the middle cranial fossa, and then continues posteriorly like a tentorial sinus all the way to then join the superior Petrosal sinus. Or, like in this case, which is a pretty common situation, you see like maybe multiple channels joining together and then coming down, going along the floor of the middle cranial fossa, and then exiting through the foramen ovale, joining the pterygoid plexus mainly. Now, in this paper by Suzuki, he looked at all like these variants and he established how like really this is the most common, like 60%. And then we have this one, this variant also pretty common, around 10%, while all these other variants are pretty rare, around 2% each. Now, moving forward, like Petrosal sinuses, this is an obvious connection shown here again in our initial image very well. We have a catheter injecting. This is the Petrosal sinus is divided into a horizontal part, a vertical part, and you see it very well also on your sagittal image here, the inferior Petrosal sinus. And if in the same view you get like some dyna CTs, okay, then you appreciate so well this the venous structure, and you can see here the connection through the clival plexus with the other side, and you see the groove of the bone with the vein filling, and you can appreciate this anatomy very well. Pterygoid plexus, we mentioned it before. This is the connection with it, where it goes through the foramen ovale, okay, and this is more or less the location of the foramen ovale, where would it be. And this is on your coronal view, is the same thing. And you see here, like 1 and 2, there it is, your foramen ovale with the pterygoid plexus going through. Or again, in your dyna CT, you can see here the foramen ovale with some veins going through on your axial view, while this is a coronal view, and you appreciate here the foramen ovale with its classical, like a little oblique direction. And you see here the veins going through. So there you go, plexus, foramen ovale. Intercavernous sinus, beautifully shown on this image. Here we have like an anterior portion, a posterior portion, but also an inferior portion. Essentially, it's a venous structure that connects the two cavernous sinuses. Then to finish, this is a demonstration. It's another patient coming for inferior petrosal sinus sampling, in which this beautiful image shows the presence of bridging veins. So let's not forget, and that the cavernous sinus may also be connected directly or indirectly with some bridging veins, some like brain veins essentially. And here, what we see on these are 3D views. You start recognizing this vein here. On this axial view, you see how these veins, they're really like, they run like within the they run in the arachnoid space. And here you recognize it on the 2D images. So these are an anterior pontomedullary vein, which is filled in some way by bridging veins coming from the cavernous sinus itself. So moving forward, we spoke about the connection of the venous structure connected to the cavernous sinus. Moving forward, I will talk briefly about the development of the cavernous sinus, more specifically about the histological development in the fetus. And there's this beautiful paper by Hashimoto in the year 2000, in which he looked at the coronal sections of the cavernous sinus region in the fetus, and he showed, like here we have 15 weeks. He showed how it really develops. And let me go through this very briefly. So just to have a perspective, in all these images, this is the pituitary gland, okay? This is the trigeminal ganglion, okay? And so this is the floor of the floor of the cavernous sinus here. So this is like essentially the sphenoid bone, okay? And here, this structure here essentially is what is or develops as the cavernous sinus. So inside, you can recognize here there's an ICA, okay, an ICA that we see how it develops and becomes larger, okay? And then, so surround what it is, the ICA is what then becomes the cavernous sinus. So the way it develops really starts like here, as you see on the first image. On this first image, you see how there's barely if any space. Yes, there are some space here indicated with the asterisks. There are some sort of lacunes, but they're more like, this is more like a whole mesenchyma with some lacunes. This starts to enlarge going forward. They start to enlarge and they start to coalesce and they become larger and larger. And here it's how this is how the cavernous sinus develops. So the cavernous sinus is a network of distinct individual veins with endothelial layer only that fuse together later in the development, creating the plexiform appearance. So it starts like that, and then it develops like that. And this leads us very well into the concept of the compartments. The concept of the compartments, which is very well illustrated by different artists. If you open, like, if you look for illustrations of the cavernous sinus and in different books and by different artists, all of them will recognize the presence of compartments in the cavernous sinus. Here it is. Look at these compartments. Different views, but the same concept. So this concept of compartment is very well understood if we consider how histologically this develops. This is just again like some axial images from a dynas CT obtained during inferior petrosal sinus sampling. And here you also understand, you see like radiographically here, you see the compartments. You see the compartment here on the coronal view, divided by some sort of like endothelial line. This is something that has been very well understood for many years, and I have to give recognition to a NOSP who, like in this, actually this was a chapter in a book, who recognized this concept very well, and he showed how actually this sort of compartmentalization develops in longitudinal sort of channels, and he describes how like the ophthalmic vein, so this is the front, this is the back, how the ophthalmic vein usually like drains through the medial aspect of the cavernous sinus, while a lateral compartment is usually joined by the superficial middle cerebral vein and so forth. And to illustrate this concept, for example, let me show you a case in which like we have here lateral view of a right ICA injection. We see immediate filling of the ophthalmic vein, and here this is a later phase in which we see how the ophthalmic vein goes anteriorly, but there's no really connection with the veins of the face in this particular case. And so when we look at the same image on a frontal view, we see how the ophthalmic vein indeed is medial, and the filling, it comes from medial. And this is like part of the concept of like these longitudinal channels that like medial tend to go to the ophthalmic vein. In this particular case, this fistula was treated with a direct puncture, like through the inferior part of the orbit, like with a classic Seldinger needle, just big enough to put a 17 microcatheter. And then once the needle reaches the point, like do an injection, we look at what kind of outflow we have, which we already saw in the arterial phase. And then we can do whatever way to close this. I mean, in this case, we put coils, but certainly like there's a discussion on it, so forth. But the concept is that you close the outflow, you close the foot of the vein, and the fistula is cured. But here I show this case to really like to express the concept of the compartment and the longitudinal segmentation of the cavernous sinus. Or, for example, this other case, this is a patient coming in with actually two fistulas. Let's forget for now about this fistula on the back, but here you see there's another fistula, right? It's a dural fistula coming from in the back of the cavernous sinus. And what is interesting is you see that the venous outflow of the fistula is through the inferior petrosal sinus here, right? While we don't see filling of the ophthalmic vein. When you go to the same injection, you go to the later phase here, now you see filling of the ophthalmic vein actually from the front to the back, the classic way in which the ophthalmic vein should drain. So this means that the compartment where the fistula drains and the compartment where the ophthalmic vein drains, they're separated. Otherwise, we would have seen outflow, or we certainly would not see the venous outflow of the face. We would not go down under this direction, which would be under stress if it's in the same compartment. So separate drainage of the fistula from the drainage of the superior ophthalmic vein. So this also leads us to the concept, to the explanation of the paracavernous sinuses venous structure. And there's all sorts of variants, and I will show some of them. This is an illustration from Max on neuroangio, in which like he shows how this is like sort of like an oblique perspective. You see the ICA, the cavernous sinus, and then you have these other sinuses, which some people call lateral cavernous sinus, paracavernous sinus, but essentially are variants that can be used by the superficial middle cerebral vein for drainage. And this concept is very well illustrated in this paper on AJNR, in which on this graph you see essentially this concept. You have a superficial middle cerebral vein that can drain straight to the cavernous sinus. It can go either together with a little superior sphenoparietal sinus to the cavernous sinus, or like here it can go straight to the cavernous sinus, or it can get out through the pterygopalatine plexus through the foramen ovale, or join like a tentorial vein and drain posteriorly. I showed you some variants before, but this is another case of a fistula in which we show how the fistula here drains toward the superior ophthalmic vein. So this is a frontal view, this is a lateral view. You have a fistula which drains all the way anteriorly like that. Now, this is the same ICA injection. So this was the right side injection. This is the left ICA injection. You see the same thing, probably some supply from the meningohypophyseal trunk, but same outflow to the superior ophthalmic vein of the left. Okay, but the interesting here is when you look at and compare the venous outflow of the fistula, and you compare it with the normal venous phase of the left-sided hemisphere, in which you look for this channel, which is the superficial middle cerebral vein, you appreciate how the superficial middle cerebral vein drains in a compartment which is completely separate. It drains in this way. So you have a cavernous sinus connected with the superior ophthalmic vein, and then you have a superficial middle cerebral vein separate from the sinus, which drains in this case through the pterygopalatine, through the pterygoid plexus. Or this other case, again, another fistula, very good to illustrate the concept. You have a fistula, you have this drainage through the inferior petrosal sinus, across through the clavicle plexus to the other side. But when you look at the venous phase of the brain, you see how this, which is the superficial middle cerebral vein, drains separately from it. And this is becomes very good when you think of like how to treat this, because you know you can close the you can close this part without affecting venous drainage. And again, the double masking comes really into play here. You see here the in white, you see essentially the arterial phase. In white is also the clavicle plexus and the inferior petrosal sinus, because these are filled in the arterial phase because there's a fistula. But you see here how the superficial middle cerebral vein is in black because this is a venous phase, and you see how they're separate. This runs into the wall or lateral to the cavernous sinus, so they're separate. And this is just after the treatment. So Max treated this with onyx. So put onyx in the region of the fistula. And this is like the final view of the ICA, in which you really like don't see any feeling. The fistula is cured. The interesting thing is that at the end, after cure, you recognize this even better by doing this double masking. You see the ICA in white, and you see here the superficial middle cerebral vein running really like to the side, not affected at all by this onyx injection. So this is an example where really like the understanding of this anatomy can come into play and lead to an appropriate treatment. So this concept can be very well understood if we think about how the cavernous sinus develops. And here you are with the embryology of the cavernous sinus. So we have to think of, in the fetus, very early fetus, we have two sort of like venous outflow. We have ophthalmic vein or primitive maxillary vein, which drains toward what we call it the prootic sinus, which is this one. And then we have the brain draining toward like what we call the primitive tentorial sinus. And these structures are completely separate. Now, what happens with the fetus developing is that the superficial middle, this lateral outflow, the brain outflow, start to be coming more medial. And it can come more medial, and eventually can join the cavernous sinus, or the joint may not happen. And this is why we see all the variants that we see in the adults. This is the same concept expressed very well by Gayoud and Samilan. They wrote quite a few papers about this concept, but essentially you have like the superficial middle cerebral vein, which according to complete or incomplete embryological fusion, like it can go posteriorly and drain toward the sigmoid sinus here. It can join medially, but remaining separate from the cavernous sinus, or as shown as C here in this example, it can join the cavernous sinus. So now these all come together when we go back to the images that I showed you before. There it is. We have here a superficial middle cerebral vein that joins the cavernous sinus. Here, same thing. It joins a little cavernous sinus, but also the pterygoid plexus, or it can remain completely separate here and draining toward the sigmoid sinus, or in this case, completely separate, remains separate, but joins here the pterygoid plexus. So to terminate, a few mentions about the venous plexus of Reitert. Again, very well illustrated with some good images from the inferior petrosal sinus sampling. Here you have a coronal view. You see, you start appreciating here, like probably the shape of the carotid. Same patient on the MRI. You see the carotid here, and now you see very well the carotid on your images, and you see how the carotid here is surrounded by a venous structure. We know it's vein because we're injecting the vein. There's no questions about it. Okay, this is what it is, the plexus of Reitert. It essentially is this this plexus of veins that surround the carotid in the Petrus canal, starting from the cavernous sinus in the Petrus canal and going down. And there it is in blue. You see the venous plexus of Reitert. Now, this is a beautiful illustration of that on your axial view. Again, we see here, this is an axial view, and this is actually a sagittal view. And you see here, this is what it is, the plexus of Reitert. So you have an ICA, and what you have here surrounding, these are venous structure. This is the venous plexus that surrounds it, and here on the sagittal view, same thing, venous plexus of Reitert. Now, this is a case, maybe a question for the experts that we have connected today. We have a patient, a young patient with a mass, which is actually causing, which is like invaded the carotid and is causing like a stenosis of the carotid. Now, what we see here, like on the MRI, can be called like, is this enhancement because of invasion from this tumor, which is a meningioma, or is this instead like visualization of the venous or the plexus of Reitert because there's less flow in the ICA shrinks, and so together with the shrinking of the ICA, you have enlargement of the venous plexus that surrounds it. I'm not sure. I'm still I'm debating, and I'm happy to hear other opinions. Anyway, to conclude, we went through the classic cavernous sinus anatomy and the vascular angiographic anatomy. We discussed the concept of like cavernous sinus compartments and variant paracellular sinus outflow, which is well explained if we think about the cavernous sinus embryology. And we talked briefly about the venous plexus of Reitert. Thank you, and I'm happy to hear any question or go forward and listen to the cases.
Thank you, Eitan. Thank you. Okay. All right. Some very positive comments in the chat. Any questions?
I have one question. It's Langer.
David.
Yeah, I mean, one of the things that we always, for example, in surgery, if there's a big sphenoparietal vein, or even taking one step further to essentially knowing what you can get away with sacrificing veins. This is in surgery. This has been a chronic issue of how we can use these. We don't understand the venous anatomy nearly as well as we understand our arterial anatomy, and we're still not as good as the arterial anatomy we think we are. What we can get away with, but sacrificing veins is just a complete black box surgically, and sometimes we spend an awful lot of time avoiding venous injury. And there's a terrific Japanese surgeon who actually repairs bridging veins, things like that, just to avoid anything. Any thoughts on that you've seen of how we can use angiography to predict what veins we can sacrifice? I mean, here's an example of these different compartments, especially let's just talk about the cavernous sinus and the veins going in. Any thoughts about that?
David, how are you?
Never had a bad day in my life, Eitan.
So I let Max answer.
I don't know. I'll punt back to we have like a floor of like amazing experts in this. So I think, I don't know, David, like, I guess, okay, fine. I'll just say, of course, like, okay, so obviously I trained under Peter Kim Nelson. He's actually upstairs doing some COVID work now. So I wish he could answer this. But of course, like when I came as a fellow, it was like Pat Kelly was here. For the surgeons, I'm sure you know who Pat was, or is, but he was the chairman at the time. He was a glioma guy primarily, but every glioma that he resected, we had angiographic preoperative evaluation with stereo images from like one of his early stereotactic systems. So I don't know, David, like I guess there's nothing like looking if you want to find something, right? Like his idea was that you want to see, primarily he did the angio to look for the veins and to understand where the veins were and what the issues were beyond like the usual lenticular striates, like whatever, all these other things that I'm sure the surgeons are familiar with. And I think this was like in many early days. Like nowadays, a lot of the stuff that needed an angio now doesn't need an angio.
Well,
so,
so Max, this is Henry talking.
yeah,
So
thank you, Henry.
he did it primarily to make sure that remember, he only used a 2-inch trephine for every single craniotomy that he did. You know, and I did every single stereotactic angiogram when I was at NYU, and he did it primarily so that way he could plan the craniotomy away from a bridging vein. In answering David's question, I think it's slightly different than Pat Kelly's issue. You're right. I think that the venous drainage of the temporal lobe in particular is different for every single patient. And if you have a large superficial middle cerebral vein that drains into the sphenoparietal sinus, drains into the cavernous sinus, et cetera, and you have no vein of Lebet and no basal vein of Rosenthal, you cannot take that vein. Otherwise, that patient will have a venous infarct. The other thing, too, is that deep in the sylvian fissure, when you're doing dissection for aneurysms, almost always the superficial sylvian venous system connects to the deep venous system, and you have to take that vein if you want to completely split the sylvian fissure. And it's variable in terms of whether you're able to see that vein or not. The bottom line is, I think, and this is why I think angiography is underappreciated on the surgical side, because yes, we pay attention only to the anatomy, and that's why people who say, oh, you can just clip aneurysms with CT angiography are not appreciating the venous information that you get from angiography, because angiography includes venography, and you can appreciate the collateral circulation of the temporal lobe, so that way you can make a determination, hey, at least give me an educated guess of whether I can sacrifice this vein in the sylvian fissure or not. And by looking at the collateral circulation and the collateral venous drainage of the sylvian fissure, I think it gives you a much better idea whether you're going to be able to get away with it, yes or no.
Henry, thank you. Yes, I think we're essentially what we're saying is a very similar thing. We have to have information.
Same thing, yeah.
Once we have that information and an anatomical knowledge, you know, that enables a safer surgical approach. Any other comments?
Max, I just want to add a comment to this. We have an increasing request. Can you hear me?
Yes, yes,
yeah.
yes.
Yeah, that's Gus from Copenhagen. We have an increasing request from our neurosurgeons to better understand the venous anatomy for the exact same reason. And I think because we lost angiography as a diagnostic tool quite a bit over the last 20 years, we have actually a hard time to predict exactly what's going to happen if you sacrifice a vein or not. Except for these extreme situations, if you have a large sylvian vein that travels into the cavernous sinus, of course, it's rather obvious that you shouldn't take that one. But the problem is there's a lot of variation in the venous anatomy and the venous drainage, and that makes it very difficult. Even if you have high quality angiograms and look carefully at the venous faces, it remains a difficult task to predict what's going to happen if you take a particular vein or not during surgery.
Thank you. Okay. Any other comments?
Incredible talk. Great talk.
Thank you, Dave.
Thank you. Thank you.
Yeah, Aidan, I just want to say one thing to the compartmentalization that you presented. First of all, it was really a very nice presentation. I liked it a lot. One thing that we probably have to keep in mind if we talk about different drainage pattern and seeing the ophthalmic vein, for example, not being connected to the fistula, or any other vein not being connected. The problem is if we read only the angiograms the way we do, mostly by arterial injections, we don't get all the information. Sometimes, so I've seen cases where you, sometimes if you go into the cavernous sinus and you had no connection to the supraophthalmic veins, you go in there and do a selective injection into the cavernous sinus, you suddenly see them. Yeah. They may be smaller, they may be partially thrombosed, but it doesn't mean necessarily that they drain into a different compartment. So thrombus formation within the cavernous sinus, especially with cavernous sinus fistulas, plays a role in how much we see.
Thank you for specifying that. Absolutely, I agree, and I'm happy you specified it to make it more clear. the compartmentalization may be dynamic, right? It may be that it's dynamic, but anatomically there may be a connection that you don't appreciate on the angiogram in that particular page.
Yes.
That is definitely for sure, because in surgery, there are definitely veins that are present that we do not appreciate on angiography when we solely do angiography.
Absolutely, Henry. And that goes to, like Eitan showed so many pictures of like how many more veins we see when we inject the veins. And there's like a whole dynamic world to that. When we inject the arteries, of course, for the larger group, you know, that's one of the things that we always teach in the fellowship. You only see the veins of the arterial territory you've injected, right? Like you may not see them all. And there's a lot more there that's like hidden. Timur, can you hear?
Yes, I can hear you.
Timur, thank you. So why don't we let's keep going. Timur, let's keep going with Timur. Again, like for most of us, needs no introduction. But if you're not familiar, please look him up. And we're like super honored to have you today. Thank you very much. Go ahead.
Can you see my screen?
Yes, we can see your screen. It's not a PowerPoint show. It's like that's it. Okay, perfect.
Okay, so we'll talk now about some access routes. I really liked the talk from Eitan because it leads very nicely into how we can now access the cavernous sinus for treatment of dural AV fistulas. In general, when we talk about treatment of dural AV fistulas, we'll have to think about the arterial route, the venous route, radiosurgery, and open surgery. And I think the cavernous sinus is one of those areas where the venous route is definitely the best, simply because the arterial approaches to the cavernous sinus are not considered as safe as the venous routes. At the cavernous sinus, we have a lot of anastomoses between the internal and the external carotid system. We can see here the artery of the foramen rotundum. We can see the artery of the foramen ovale, and they are interconnected via the ILT to the ICA, and this has been described, and I think all of you are experts in the anatomy, so I will not go through this. But at this area of the cavernous sinus, there's a significant amount of cranial nerve supply and a significant amount of ICA to ECA anastomosis, in particular via the accessory meningeal artery, the middle meningeal artery, the Vidian artery, and the aforementioned artery of the foramen rotundum and the artery of the foramen ovale. And here are a couple of these examples. For example, here, this is the IMX going towards the artery of the foramen rotundum that then enters at the level of the ILT into the ICA that you can see here. Then we have here the artery of the foramen ovale that will enter again via the inferior lateral trunk into the ICA, and you can see here the washout into the ICA. And these arteries are always present in patients with, what's this? Okay, in patients with dural arteriovenous fistula, or in this case here with an AVM of the ophthalmic artery. And finally, we have here the Vidian artery that interconnects through the mandibular artery to the ICA that you can see nicely here. So these are your dangerous anastomosis, which is why I believe that an arterial approach to the cavernous sinus is associated with a higher risk of inadvertent embolization into ICA and MCA. You've heard about the venous anatomy of the cavernous sinus. We have multiple different routes. Here we have the superior ophthalmic vein, inferior ophthalmic vein, the vein of the foramen ovale, the inferior parietal Petrosal sinus, superior Petrosal sinus, the uncal vein. We have via or not the sphenoparietal one, the connection to the superficial middle cerebral vein, and we have the intercavernous sinus. And some of these areas are like more dangerous. If you think about cortical venous reflux, that's mainly into the superficial middle cerebral vein and into the uncal vein. And some of those routes are pretty good for venous access, and these are the ones that we can use for the venous access. And I will briefly go through a couple of examples here. The preferred route is, of course, via the inferior petrosal sinus. It's the direct highway into the cavernous sinus, and we can easily then disconnect the cavernous, the dural arteriovenous fistula here through the IPS. And we can use the superior ophthalmic vein, as in this example here. We can use, if the superior ophthalmic vein is not present, we can use the superficial temporal vein, as in this example here, which can be a little bit more tricky from the access, but is still possible. We can use via the contralateral IPS the intercavernous sinus to get into the fistulous compartment. And in general, we say that the easiest access is the one that we see first. However, if we don't find an IPS, as in this example here, if we only have reflux of this dural arteriovenous fistula into the uncal vein and from the uncal vein into the deep venous system of the posterior fossa, then it may be more difficult to access this case here. There's no superior ophthalmic vein, and our typical access routes are not present. And as I said, an arterial approach, although it looks quite interesting here, is dangerous, as these vessels are invariably interconnected through the ILT and the MMT to the ICA, and therefore injecting from here from an arterial route does cause, or will cause likely, problems with inadvertent embolization into the ICA. So in these cases, we propose to approach through the non-visualized venous segments, and the reasons for non-visualization of a venous segment are various. For example, we can have thrombotic occlusion. This was described and discussed previously, which can be induced by the shunt or being the cause of the shunt. We can have anatomic variations, i.e. a true absence of the non-visualized segment, and the visualized or venous segment may not be visualized because it's used to drain normal brain, not the shunt, i.e. we are not simply opacifying it. And how can you identify what is present in a single patient or in your individual patient? And for this, what I like to look at is always at the CT of the patient. So in this particular case here, we look at the CT and we look whether the IPS is present or not. And in this case here, right-sided dural arteriovenous fistula, you can see the left IPS is not only present, but also opacified. The right IPS is non-opacified, but it was present, as you can see a notch here in the bone, and therefore you know that this area here is truly thrombosed. And this means that you can re-access the cavernous sinus through this thrombosed channel. And I will show you here now the example here, a higher cut of the same patient. There's the dural arteriovenous fistula. You can see the IPS on this side, and on this side, there's a small notch in the bone. So you know it was there, but it's currently thrombosed. But it means that you can access it and you can recanalize this occluded segment. So in this case here, we go venously, we do a jugular vein injection that demonstrates the occluded IPS. We use a triaxial system for stability. We perform an arterial roadmap, and then we enter through the occluded IPS with classically a glide wire that we insert into the occluded IPS and use like slow rotational movements to advance it through the IPS. It is helpful to have a triaxial system and to wedge your guide catheter into the IPS, i.e. pointing the catheter medially and anteriorly. This is your classical access road. And then once you have gained access with your 35 glide, you can then do a blank roadmap, i.e. remove the 35 glide wire, have a blank roadmap, and this will allow you then to go up with your microcatheter along the channel that you have just made and insert the microcatheter then into the cavernous sinus. Here you can see how we go along this now established or reopened IPS into the cavernous sinus. And once we are in the cavernous sinus, we can then do a microcatheter injection to verify the position of the catheter in the sinus. I typically like to go into the origin of the vein that caused the cortical reflux. In this case here, we went with the catheter into the into the basal uncal vein here, and then started to disconnect at this level here with a couple of coils to disconnect first the reflux prior to then treating the remainder of the dural arteriovenous fistula. And this is the follow-up result. We coil from distal to proximal. I like to use thrombogenic coils. If possible, I like to have dual access to, at the very end, inject a couple of droplets of glue, as it's very thrombogenic and can then lead to complete obliteration of the dural arteriovenous fistula. And here's the follow-up after treatment with the occlusion of the fistula. So we have described our experience to go through occluded venous segments together with a group of Sirentara Pongpech in 2011. And here are a couple of examples. Here's a patient with left-sided dural arteriovenous fistula. We can see the cortical venous reflux going towards the middle superficial cerebral vein here. We can see reflux into the deep venous system as well. We see again the combination of the ILT and MLT through the vein of the through the artery of the foramen ovale and rotundum, and its communication with ICA branches, which again makes it very dangerous to perform an arterial route in these patients. From a venous access point, we can see that these veins will be very difficult to reach via transvenous approach. There's no superior ophthalmic vein present. There's no IPS present. However, in this left-sided fistula, we can see very nicely again here the notch of the IPS. The right-sided IPS is still present. The left-sided IPS was present, but is only thrombosed. But it tells you that you can access this fistula through the left occluded IPS. You know that this channel is there. You point your catheter anteriorly and medially, you wedge it into the origin of the IPS. And then I like to go up first with the glide wire, make a blank roadmap, and then go up with the microcatheter. The reason why I don't like to go immediately up with a microcatheter is that I have less forward pushability with the microcatheter. If I put the wire out too much, then the microguide wire is again having not enough pushability. If I have the microguide wire only a little bit out, then there's I think a higher risk for perforation, which you don't have with the 35 or even a 38 Terumo glide wire, which is my preferred method. And then once I am in the catheter, once I'm in the cavernous sinus, screen sharing has stopped. I don't know what has just happened.
We see you, Timo, but we don't see the slides.
Yep, I don't know what happened. So I'll just. Oh, there was a problem with Microsoft PowerPoint. Okay. Then. Sorry about this. I'll have to just open it again. Can you see my screen?
We can, yeah.
Okay. So I'm trying to open PowerPoint. Sorry for this.
It's okay. Take your time, Timo.
Okay.
Yeah.
Can you see my screen now?
We can see it. It's more like in the presenter format now. You know how you can see on the side, like the next slide and whatever. But we can see. You can see some of that. Uh-huh.
Okay.
Yep. Yep.
Good,
Okay.
good, good.
So that's
Sorry about this.
Uh-huh.
So we move forward. Ah, yeah. So this is the case that I was just describing. So once I'm in the cavernous sinus, what I like to do is to perform a 3D venous injection. And this allows us to demonstrate the cavernous sinus anatomy. It allows us to visualize where we have the cortical venous reflux. You can see here the inflow into the middle superficial cerebral vein via the presumed sphenoparietal sinus. You can see where your cranial nerves are likely to be. You can see where the fistula zone is. And this 3D roadmap will then allow us to go into the area first that demonstrates the reflux, i.e. I'll take this area first here in this case, put some course into the sphenoparietal sinus and thus occluding the fistula. Here's another example, same thing, catheter pointing medially and anteriorly. We go up to the glide wire, we make a blank roadmap, and then once we are in the compartment, we start coiling from distal to proximal and occlude the thing. I like to use soft detachable coils to disconnect the cortical venous reflux first, and then to fill the cavernous sinus, I like to use thrombogenic, i.e. fibered coils, if possible, this is rare, the Nestor ones or interlock vortex, and I do not have any conflicts of interest here. To finish, I like glue over onyx because glue is more thrombogenic and there's a reduced risk to penetrate into the vasa nervorum. If you use onyx, just don't over-inject. So here's an example where we actually used onyx rather than glue. We can see here again the feeding arteries. We see the IPS that likely entered here. We look at the CT. If we see that there's a notch, we go up through the IPS. We recanalize the IPS pointing medially and anteriorly. If you use a triaxial system with a glide cath, you can really nicely wedge yourself into the artery. Hi, I'm in a Zoom meeting. Sure, I will. Thanks, bye. And then once you are in the cavernous sinus, we started here with first disconnecting the reflux, and then finish the job with, in this case here, onyx. But with onyx, you have to be a bit more careful. Glue is just like more thrombogenic and therefore helps nicely. A couple of operative nuances. It can help you a lot to identify the fistulous zone correctly. So for this, we like to use both 3D on the arterial side and the 3D on the venous side and then superimpose them, because this will sometimes allow you to visualize that the shunting zone is not in the entire cavernous sinus, but maybe in one of those parasinuses of the cavernous sinus. And then just by using one or two very small coils, you are able to disconnect it. So in this case here, you can identify that all of the feeding arteries go into one venous channel or one venous segment right here. Then we do, here you can see that they are all going in this segment here. And then you can get with your microcatheter into this segment, put in just 2 or 3 small coils into the segment, and disconnect the fistula without having to fill the entire cavernous sinus with your thrombogenic coils. And this prevents you from one of the complications of transvenous approaches, which is that if you fill your cavernous sinus too much with a lot of coils, then there's a high risk of there's a higher risk of cranial nerve palsy due to compression. especially if you overpack your cavernous sinus. And it can be helpful to just go into the segment where the fistulous component is and then just take this one. Here's another example where we just took like the fistulous component, and this allowed us to disconnect the fistula without having to go through the entire, without having to fill the entire cavernous sinus, which costs more money and it's actually putting the patient at risk. Another thing to remember is that you should first obliterate the reflux and then pack the fistulous zone. So you have to coil from distal to proximal. So you first go into the area where the reflux is. And this is what we didn't do in this case here. And you can still see that there is reflux here via the basal vein of Rosenthal, which then necessitated, obviously, an operative exploration. And here you can see the basal vein of Rosenthal exiting from the cavernous sinus, and it needed to be clipped. Same here. Another operative nuance in some cases where you have like a significantly high flow type of dural arteriovenous fistula. This is the case here with the accessory meningeal artery going into the venous system here, significant venous pouches. If you have this type of scenario, then you can use an arterial approach, but use your arterial approach to just get into the vein, i.e. from the arterial side, we went into the vein with 2 microcatheters and then were able to, you can see nicely the maximally dilated artery and the vein. Right there is the fistulous connection. So in this case here, we thus went into, here again, there's the fistulous connection from the artery into the vein. We went from the artery to the vein and then started filling retrogradally with coils and finishing the job, I think, with glue in this case here. This is pre-treatment. See nicely again the additional access from the Vidian artery and the mandibular artery. And this is post-treatment. And if you have these high flow fistulas, we typically have the patient on heparin, and we do a CT scan after stopping the heparin to ensure that we don't have overshooting thrombosis. In this case here, we see overshooting thrombosis, and therefore we had to start again the heparin to prevent sinus or like overshooting thrombosis, which can happen in these high flow fistulas. And this is the same patient on 6 months follow-up, and he did very well. So these were just a couple of examples with a couple of operative nuances. To conclude, for cavernous sinus dural AV fistula, I like a transvenous approach. I like to go through the IPS even when it's occluded, but you have to ensure its anatomical presence by looking at the CT, contrast enhanced CT. And then we try to only go for the fistulous zone if possible. If this is not possible, we first go for the cortical reflux, and remember the compartmentalization that also Eitan had described. Okay.
Timo, thank you so much. This is amazing. There's so much in there. So while we were talking, there's a couple of questions came up. One, so we'll take some of those and then any others. So one question was about the risk of this whole inferior petrosal sinus approach. What's the risk of rupture or some other complication? Can you comment?
Okay, so I think it depends on like, we have not seen rupture of the IPS, but what we have done is we are not going up there with a microcatheter. because I believe that the microcatheter and the microguide wire are more dangerous than a 35 or 38 glide wire. And we don't shove the glide wire up, but we just perform a rotational movement with very like mild forward pressure. And this rotational movement, you can actually see the catheter or the wire tip like slightly moving. And you should not have any like resistance. In the moment where you have any resistance, you're in the wrong channel. You may be in actually typically the wrong channel that you can get is the basilar plexus of the clivus. But then your glide wire will just not advance. And it takes approximately 5 minutes to go through an occluded segment. If you're not able to get in there, like in this period in time, you know that you're in the wrong channel. More often than not, can you see on your Dyna CT or Vaso CT where your anatomical and bony landmarks are. And it's very helpful to wedge like a hydrophilic, like a legato, for example, into the IPS, because then you have a good like forward pressure. And again, in the moment where you have any resistance, you're in the wrong channel. But if you have no resistance, it often goes very like surprisingly smoothly up through the channel.
Thank you. What happens if you don't see the channel on CT?
If I don't have a channel on CT, it means it's not there. It's anatomically not there. And then I can't go through through that side. Then I would try presumably to go via the right side.
How often did it happen that you didn't see a channel? Because like embryologically, we think that should be like a rare instance. Extremely
rare. I think I have one case where we have where we had a very small IPS, the bony notch was just like tiny. So I thought that this may have been a hypoplastic case. And in this case, we went from the contralateral side and then through the intercavernous sinus.
There was a question earlier about the compartments, this whole idea of we love those magic bullet cases where you could just kill it just where it's just where the fistula is, right? And then you spare the sinus. The question was more or less like how, is it difficult? Like how often what happens if you're looking, you can't find the compartment? Like there's a lot to talk about there, but can you comment?
So if you don't find the compartment, so first of all, I think it's very helpful to have both the arterial roadmap and an arterial 3D and a venous 3D. The arterial 3D, especially if you're then doing Dyna CT or Vaso CT type of picture, will allow you to show very nicely where are the arteries and where is the vein. And where's the first compartment of the vein. And if you then superimpose this with the venous 3D, you will be able to know whether you can, from your current position of the cavernous sinus, enter into this compartment. So first, your arterial 3D, you do Vaso CT, you visualize where exactly the fistula zone is, and then you superimpose this with your venous 3D, where you are able to visualize where exactly you can go into, whether you can get into this compartment.
Okay. I mean, I'm sure that it's a labor-intensive process, right? So it's something that I think we could probably show as a case, but it would have to be like compressed as a video or something like this to show how this progresses. Do you use any of these advanced Dyna or whatever techniques to verify that you're in the right compartment? Like say you get there by some means, what then?
So if I'm not sure whether I'm in the right compartment, I may do another Dyna CT, but this is rare because it's a lot of radiation. So typically, just by micro injecting with the microcatheter in the venous compartment, you will be able to see whether you are in the right portion.
Any other questions? There was a question of like which kind of glide wire you use, like an angled or a straight, when you access the sinus.
So I use my simple straight Terumo glide wire, the 35. It's straight.
Straight tip.
I don't use a curved one because with the curved one, I don't have it doesn't allow me to have the forward pressure.
All right. Any other questions? Let's see. Anything from the chat? Okay. Timo, thank you so much.
Perfect, thanks.
Thank you. And again, thank you for also like I know you have your departmental responsibilities that coincide with this time, and you've been able to shift that to participate. So thank you so much. Bendorf, can you hear?
Can you hear me?
Yes, yes, we can hear you. Again, also thank you so much for joining. We really have like a all-star lineup today, so it's incredible.
Yeah. So there will be some overlap because you told me that Timo was going to talk about superior petrosal sinus. So I prepared some slides for the IPS.
I couldn't keep them straight.
So there will be some redundancy now, and I apologize for that from the beginning, but there's maybe a few differences that
No, please don't apologize. It's like, you know, repetition is the mother of learning. Like we're all that there's really, it's like, that's what it's about.
So can you see my slide?
We cannot yet. We see you, but not the slides.
Okay, let me see what's going on here. Doesn't open properly. I don't know why. Can you see it now?
Not yet.
Okay. That is strange because you saw my stuff. Do I need to click on, you know, and I'm not.
You, so what you need, you see that share screen at the bottom? If you look at, or like.
Yeah, okay.
Yeah.
I click on multiple.
So share screen.
Okay, I did.
And then you click on the screen you want to share, and then you hit like another share button.
I see multiple participants can share simultaneously. Is that what I?
Right. So did you click? There's like a side thing, and then there's the share screen, the main like green thing, the main green button that says share screen.
Yes. Okay.
Great. Okay.
Okay. Sorry. See it now?
Yes. And Dodi, hi. We got your question. We'll get to it. Go ahead.
Dodi is there.
Dodi is there. He has some arterial questions on Cavernous Sinus. We'll get to that later. Thanks, Dodi.
Okay. So what I want to talk about is a little bit more in detail about the IPS approach and how I do it for quite some time now. And I want to just start with like a typical case where we actually do not have a lot of problems to go up there. If the IPS is open, of course, that's usually the preferred route to take and to get up into the cavernous sinus, either ipsilateral or contralateral. If the IPS is not visualized, like in this case where you see isolated drainage from the posterior cavernous sinus through a paracavernous sinus into the right sylvian vein, we still try to do the same thing. I want to show another case that is actually 20 years old to make a point. This was a case I treated in 2000. And what was particular about this case, she was misdiagnosed for quite some time, had very severe symptoms. And after a couple of MRIs not diagnosing the fistula, she came to us. We did an angiogram. And this is what we saw. That is a case actually that is in the book. So some of you may know this case. And I'm showing this only to demonstrate one thing, not that this is a small fistula, but there was no IPS drainage in this case, and there was no IPS visualization on the right side. There was a little bit on the left side. So this is the same case. This is the injection from the venous side, and this is what I was talking about. If you do a proper phlebogram from the jugular bulb, you see a lot more venous anatomy that you can appreciate from the arterial injections. So that's why I personally believe to make an assessment of the venous anatomy from arterial injection is very incomplete and often misleading. So this is not what we do. We rely quite a bit on the phlebogram from the jugular bulb. This is the rest of the case. I'm not going to show much treatment. I think my presentation is focusing on approaches. So this is the same case showing again the difference between arterial injection and the injection from the jugular bulb. You see nicely both SPS, IPS, cavernous sinus. You even see the rectoxic sinus that Aitan showed very nicely. This is the same from AP view. Same patient, very different anatomy that you visualize. So this is why I personally believe in order to make a decision which approach to use, especially when it comes to the IPS approach, requires good venous studies. And one way of doing this is doing a nice phlebogram. Timo, I think he covered some of that stuff, why we may not see a particular venous structure like the IPS, variations. There's poor quality angiograms, misreadings also, of course, and relatively frequently we have thrombosis of the IPS, of course, but that doesn't mean the IPS is not there. So we will always try to do a selective catheterization after we receive the phlebogram. And what I do differently from Timo is I never use a 35 guide wire. I always use a microcatheter and a microguide wire because I'm on the opposite front. I think this is less traumatic. And the two cases I witnessed, the two cases of rupturing an IPS during transvenous catheterization were caused by a 35 guide wire. There were no my cases because I have never even tried it. I had no problems actually to go through even a heavily thrombosed IPS with a microcatheter and a guide wire. So this is the technique we use. So it's for the phlebogram, it's a large volume injection. I take a 20 cc syringe, usually do a manual injection, and sometimes I repeat the injection if I don't see enough, and I will show you in one case why this may be necessary. In some cases, I do a 3D rotational DSA also to better understand the anatomy. This is just one more case. It's also an older case where you see actually no IPS drainage. And if you look for something like this here, then we see mostly the shunt is on the posterior portion of the cavernous sinus, but you see these little tracks here. You see what I call a stump of the IPS, actually of both. So that usually means the IPS has recently thrombosed and is oftentimes not too difficult to catheterize. This again is a late venous phase from the arterial injection. Sorry, you don't see any IPS here. This is the phlebogram. So if you see something like this, you may think this is the IPS, but in this case it is not. It's actually inferior petroclival vein. So we had to modify this. And if you compare in lateral view, for example, then the vein is oftentimes a little bit more anterior and a little bit more lateral, in fact. So we went for the IPS, and eventually it was not too difficult to go up there. But you see in the slide, initially we went into the inferior petroclival vein and we stopped here. So we pulled out and went then through the IPS. So knowing a little bit how the vein looks like versus the IPS itself also helps to get oriented. I saw there was a question in the chat room about how to actually recognize the IPS if you go up there, and I will show a couple of slides that show me this. This is the rest of the treatment. I'm not going to show more slides of occlusion cases. Again, this is another case, a more recent case where you see there was actually a high flow left-sided fistula. Again, you see the stump here, so that tells you the IPS is very likely there. Again, late venous phase of the arterial injections. You see that there is a faint opacification of the IPS, sometimes difficult to see, but if you take a closer look, you may see it. This is the flavogram, and this is what I wanted to point out. What we are looking for in the flavogram is something like this. It looks like a small tapered cone. I called it a notch. And this is most of the time, if you go in here, so of course, I agree with Timo how to orient the catheter. I use a hockey stick often. I used an envoy hockey stick for many, many years. Now I also use more frequently 3-axial access because it makes things a little bit easier. But if you look at this flavogram, look for something like this. It's a tiny little notch. As soon as you go in here with a microcatheter, then follow with the wire. And if you use a loop and not a tip wire, so with a sharp tip leading, then it's not too difficult to go up there. This is the case. And then you see the typical and lateral. This is the typical. So the IPS is a straight structure, usually. You have two portions, horizontal and the vertical portions. I'm going to show another slide how this looks like in AP. But if you see the catheter takes this route, you are very, very likely in the IPS going up to the cavernous sinus. This is another case, again, no drainage into the IPS and only posterior, similar to the one that Timo showed. Again, late venous phase, so no drainage into the IPS and no drainage from the brain parenchyma, so there's no IPS visualized. This is the flavogram, and I'm showing this slide just to make one point. If you try to find the IPS, sometimes people struggle and say, I couldn't find it, I couldn't find it. And I agree, there are some cases where it is more difficult and more time consuming. One thing I learned is if you are too high up with your guiding catheter and do your flavogram, you may miss it, because you inject actually above the entry point of the IPS, even if it's a rather typical entry point. This is not too low, but you see the catheter was pulled down here. This is the first injection, second injection, and suddenly you see much more anatomy. So this is a little trick to keep in mind. If you do the flavogram, make sure you're not too high up with your catheter. You may just inject the contrast into the transverse sinus and don't see enough of the structures around the jugular bulb, actually. Again, this is AP lateral view. You can get lost here in that structure, which is the infrapetroclival vein. Make sure in lateral view you're posterior, and then you follow this route. Again, the sinus has a straight route. In AP, you see actually two segments. This is a little bit more oblique medially, and then the rest goes up relatively straight. Here you see, this is actually also from an old paper that we published in 2000, where we started doing this. We started doing this actually a little bit earlier, but this is when we published this technique. I still do the exact same thing. I place a coaxial system, or nowadays maybe a 3-axial system. I take a microcatheter, take a soft J wire. I make a J of a 14 wire, can be a Traxxas, can be a Saishikai, and then I go up and follow with a microcatheter. If I'm sometimes not certain or have resistance, like in the case here, I do a very careful injection through the microcatheter to verify that I have no extravasation and I'm not in a bridging vein, for example. And usually it's possible to just advance. If you pull back a little bit and have the loop leading your microcatheter, you can get almost always into the cavernous sinus. You can go across to the contralateral side and coil and whatever you have to do. This is another case. Left-sided cavernous sinus fistula, again, drainage anteriorly into supraophthalmic vein, posteriorly into the suprapetrosal sinus, and then the deep venous drainage. And here you see a very large IPS on the right side, but the fistula is on the left side. So of course you would try to go for the left side, and that's what we did. The left side was not visualized, not draining the fistula and not visualized by the brain parenchyma. So this is another jugular flavogram. And the same thing here, you see this little notch here, you go in there with a microcatheter. This is lateral view, AP view. And yeah, you see the guiding catheter again is a little bit lower here. Sorry. Guiding catheter is here, not at the jugular bulb. This can be quite useful. And then we went up with a microcatheter. This is one injection just to verify again that we are in the right structure. And it's a very careful injection. Don't apply any pressure. One thing I want to emphasize is in AP view, I use a caudal angulation, because that makes it easier to see the two segments, the horizontal and the vertical segment. And if you see that, then you know you're on the IPS. This is a very safe method to verify that you're on the infrapetroral sinus. So if you, let's say it's thrombosed, this is partially thrombosed here, wasn't too difficult. You see again, these are the two shapes that the microcatheter has to take. This is lateral view, this is AP view. Here again, you see horizontal, vertical segment, you see here the scheme. This is what I try to use to verify that I'm in the right structure. This is just another illustration to show how the IPS travels up here and why do you see these different, two different segments if you do an angiogram or if you go up there with your wire. Another case, no IPS visible, same thing. One more point here. This is the AP view, two AP views of a jugular flebogram. And that is a standard projection here. And you see there's a lot of superimposition here. You don't see very well the IPS, all the veins around the anterior condylar confluence that sits here. So if you angulate caudally, you actually get a much better projection and have a much better understanding of this anatomy. You see here now very nicely inferior petroclival vein and the IPS. In T and lateral view again, remember the vein is a little bit more caudal and travels extracranially while the IPS is intracranial. This was one of the first images that I showed where we went up there. I'm coming back now to the last case, which was also seen in one of the first slides. This is a more recent case, and I'm just showing that we are facing the same situation very often. There's no IPS. When this patient came in, actually she came and presented with an intracranial hemorrhage. And she had this exclusive cortical venous drainage, and we felt she had to be treated as quickly as possible. One of our colleagues suggested direct cavernous sinus puncture. I said, let's see what we can find if we go up there. And this is the flebogram. Again, you see the notch here. And here's the IPS. See again, guiding catheter is a little bit below, maybe 1-2 centimeters below the jugular bulb. And this is the microcatheter going in there, AP and lateral. Again, you see the two segments of the IPS. This is the microcatheter in the cavernous sinus. I switched the roadmap here, so I then use the arterial roadmap to make sure that I am in the cavernous sinus portion I want to be in. What I often do is, just to make one more technical point here, is I often use at least 2 microcatheters in most cases. Sorry. The reason is I feel more comfortable having 2 catheters in different compartments of the cavernous sinus. I usually place one in the anterior compartment of the cavernous sinus or the supraophthalmic vein. And then I place the other one where I want to start coiling, for example. And even in a thrombosed, as you saw here, and very narrow IPS, as soon as you pass 1 microcatheter, it is not a big deal to come with number 2 and number 3 if you want to, or if you have to. If you have bilateral shunting, for example, you can place one on the contralateral side and coil one portion after the other. So you have a lot of freedom. If you lose access, let's say you get pushed back with your first catheter, you always have a second one that you can maneuver or just coil where you think you have to coil. First slide again, just to make a point. I would never skip the flebogram because it tells you so much more about this particular anatomy here, and is very helpful, I think, to develop a good strategy how to treat. This is again from a different case. This is what you can achieve with nice. We saw very nice images from Reitert, and this is very similar injection through Petrosal sinus sampling, 3D images that help me. These are older images. They are more than 10 years old now, but they actually help me a lot to learn and to understand the venous anatomy in this particular region. Especially, I learned what's the rectoxic sinus or plexus. It's more plexus than a sinus, etc., etc. And this is another patient with a 3D reconstruction. So just emphasizing the same. Understanding venous anatomy is really helpful. So bottom line, the arteriograms that we often discuss to develop a strategy, in my opinion, are insufficient. So at least in many cases. So I would always try to go for either venograms or venous 3D imaging or a phlebogram, which in my opinion, especially for the IPS approach, has a tremendous value. And the so-called occult IPS or non-visualized IPS or whatever you call it is much more often present than we think. Thank you, that was all.
Thank you, Goetz. Thank you so much. This is it's just great stuff. And for everybody, you could see how like patterns emerge and how there are similarities and how there are different techniques, but the ideas or approaches are very similar in many ways. Okay, so there are questions. Any questions to anyone? Goetz or anybody? Let's see.
I have a question. Goetz,
Yeah.
I'm not sure if you showed anything about it. I was. Have you ever catheterized the preterclival vein to get to the cavernous sinus?
Only the case I showed accidentally. So I know it's an approach that you can also use. You can basically use any approach, any vein, any venous structure, sinus or vein that is open, draining, and leads you to the cavernous sinus. The reason why I would, at least compared to the IPS, not prefer the vein unless it's really widely open, and there's a case report out there describing this approach, is it's a vein, and I think it's, if you want to go up there and have to apply some, navigation force, it's a structure that you can easier damage, in my opinion, than any sinus. The IPS is like a small, rigid pipe. So in order to perforate it, you actually have to apply quite some force, or you take a 35 guide wire.
Tima, you want to defend that? I guess
No.
you're being put on the spot.
Timo, you're muted.
Okay, let me see. Oh,
Oops.
okay, go ahead.
Now I'm unmuted.
You got it.
So I think who cures is right, and Götz has excellent experience with his technique. I like my technique. I think just like some people like stent-assisted coiling versus balloon-assisted coiling. In the end, if you get a good result, then it works. I personally believe that if you are going very slowly up, then the rounded tip of the Terumo 35 or even the Terumo 38 is less traumatic as compared to the micro guide wire. If you just look at the cross difference, it's like a stylet. So I would fear that there's a higher risk.
But it's only, Timo, it's only a stylet if you use the tip. If you advance the guide wire with a loop, as we do on many other occasions, not just in this one, it's very atraumatic. And with the loop, actually the loop can get you much easier because it's flexible. And if, let's say you have thrombus formation in the IPS and it's very irregular, which is sometimes the case, the loop actually sneaking through easier than any stiff structure that you try to advance. At least that's my experience.
Yeah, and I think it depends also on when the thrombosis happened, i.e. if the thrombus is like very old, it's more difficult to get through it as compared to like thrombus that is just like a couple of weeks or even days old. Here, there the thrombus is way easier to get up.
Yes, I totally agree. Yeah. Some cases you're surprised actually. In some cases the thrombus is so fresh it just goes through and you think you have to struggle, but you're so quickly in the cavernous sinus you can't actually believe it. So it's always worth trying, in my opinion. And often in cases that have a recent clinical deteriorations, what happens in some of the cavernous sinus fistulas is that if the present acutely with ophthalmic symptoms. Let's say they were relatively stable, had maybe a minor eye redness, and suddenly there's a change. So they develop a more pronounced exophthalmos and a more oculomotor nerve palsies, or obtusense nerve palsies, or whatever. Within a couple of days, that often means the IPS just thrombosed. So the drainage is rerouted towards the anterior portion of the cavernous sinus and the supraophthalmic veins. And in those cases, the IPS thrombosis is so fresh that it's not very difficult at all. You can probably take anything to get through it. That's at least what I've seen in a couple of cases.
Yeah, I fully agree.
Okay. Any other questions? Let's see. Okay. Question about perforation management. I don't think, these were not your cases, right? Where you saw perforations. Like, what's the risk of perforating a venous structure? So you try to go up some sinus and you're not in the sinus, or something else happens. Is that like,
yeah.
How bad is that?
You want me to answer that? You want me to answer that?
Anyone who can come.
There's actually a comment by Jacques Dion in which he had 2 perforations. I guess he means with the micro guide wire, and in both cases he had a completely benign outcome.
Okay.
I have seen one, just to answer that question, I've not seen any IPS perforation. So maybe I was just lucky over the years, it's possible. What I have seen in one other case where I was in the cavernous sinus and tried to reach an anterior compartment that seemed to be really separate, either by thrombus or by anatomic septation, I don't know. And I struggled to get into that compartment. I caused a small perforation and had a small extravasation with not a lot of clinical, this was many years ago, not a lot of clinical sequelae. Patient fully recovered. So, but this was not the IPS itself. It was in a different compartment further out in the anterior cavernous sinus region. It's the only perforation I have seen, yes.
Okay. You'd also showed something that's, I think, doesn't get a lot of play, which is use of multiple catheters, right? One of the issues for the larger group, one of the issues of working in the cavernous sinus is painting yourself into the wrong corner, and leaving some of the fistula open while you've like painted yourself out of it. We've had that experience. In fact, once from trying to find that magic compartment, and in fact, like that not working out very well. So is that like, would that be the reason to use multiple catheters? Any other reasons?
No, that's the main reason. I think in the beginning when we started treating these fistulas, very similar to what was said by Timo is, I mean, the basic rule is if you have anterior drainage, we used to start in the anterior portion of the cavernous sinus, or the transition from the cavernous sinus into the supraophthalmic vein. I used to start calling maybe the last centimeter of the supraophthalmic vein and then came backwards into the cavernous sinus. I also used to place more coils. The other rule that we always followed, that's actually was put out by Van Halbach in one of his early papers in the late 90s, beautiful papers that he wrote on how to embolize these fistulas, was always go for the cortical venous drainage first, if there is one. So try to block that. And sometimes if you have a complex fistula with different outlets, it becomes a little bit a problem. What do you do first? Where do you place your one single catheter first? And how do you maneuver your one microcatheter from that one spot to the next compartment? So that's why I think, I don't know exactly when I started doing this, but it's maybe 15 years ago or so I started, if I can, and it's actually amazing if you see a thrombosed IPS and you can just move up there with another catheter and another catheter. So I started doing this because I felt safer. It's not always necessary. So I have also cases where I realized at the end of the procedure, fistula closed down and the second catheter was not needed. But I rather have a backup catheter in place rather than losing position. For example, so I think Timo showed a case where he had residual drainage into the deep venous system, and then the patient had to be operated. This can happen. if you get pushed back, for example, too early, or you could push back into the IPS while the fistula is still shunting elsewhere. So this is my rationale to use more than one microcatheter.
I fully agree. I like, if possible, I like to have two catheters up. It's sometimes not possible because we just got like one up and struggled quite a bit. But it is, in certain cases, definitely helpful to then end with the second catheter and just continue coiling into the segment that you've lost access to with your first catheter. And
Right.
it's especially helpful when you are able to identify where's your where's your shunting zone, so that you start coiling in this area.
Yes. I have had cases, I remember one case where I had cortical drainage in the sylvian vein on one side and deep venous drainage on the other side. So and then you decide which cortical drainage or which deep, what do you plug first? So this was one scenario where I felt it's good to have two catheters in place. Of course, you can call simultaneously if you have to, but I try to then go after one outlet and then pick the next one. In case, I'm sorry?
There's an interpreter.
Okay.
Huh?
So to follow up on that, obviously, I think like we have a lot of preference for using coils, and Timo, you've mentioned at the end, like plugging with some glue. But the mainstay appears to be coils. So in terms of like the access between compartments and painting ourselves out of compartments, at least in theory, the use of a liquid embolic, like whatever, I don't know, glue, onyx fill, whatever we got, seems like it would have some advantages, right? We've used that on occasion. What do you think?
So I personally think that it helps to finish the job, to completely treat it in my personal hands. I think that there's still a certain risk of refluxing into the arteries, and then you're very fast in the MCA with your onyx. And for glue, because you can't inject so much glue because it will harden upon contact with all of the blood that is in the venous system. It will harden too early, and therefore you will not be able to cure the fistula. So therefore, I would not go with, for sure not with glue, because I can't completely occlude the fistula. And with onyx, I would be more wary about having to fill the entire cavernous sinus, therefore having quite a bit of mass effect on the adjacent cranial nerve, and the risk of refluxing into the arteries, into the abundance of arteries that are around and that can lead immediately then to droplets of onyx in the MCA. And we've seen this.
I would agree with that. And if I almost never, I think, used any liquid in cavernous sinus fistulas, I never felt I had to. If I see a small residual shunting, unless it looks worrisome to me and I cannot coil it, I leave it. And oftentimes the patient comes back and it's closed off in the follow-up. But if I had to, I would use glue also instead of, and just a little bit to accelerate the thrombotic formation in the cavernous sinus versus onyx. Dottie, I see you now. Hey.
Dottie had a question, something about arterial approach. Where is that question? Dottie.
Hello, everybody. I'm sorry I've been late today because of other stupid meetings. And so I missed the first hour. So I'm really sorry, because I hope you did well. You did not do
or survived.
No, yeah, artery. We know that arterial approach to this cavernous sinus is very dangerous because you know, all the arteries going there are also going to cranial nerves. But I don't know if you already talked about it, in Balthazar, we discussed also the possible arterial route to some dural AV fistula of the cavernous sinus. If I can, I show a couple of slides, and so that will be easier to understand. But of course, if you are interested.
Sure. No, of course. Go ahead, Dori. I've accused myself of cowardice because I have cases on the website of arterial embolizations, and now I'm too chicken to show them.
No, but maybe.
But you know, pay the price at one occasion. But anyway, go ahead.
So, can you see my screen?
No.
You should. No?
We want to.
I do see your screen. Maybe Goetz, can you stop sharing your screen?
I did. I thought I paused.
Okay, let me see. I can probably do that.
Sorry.
You're viewing. Okay, hold on.
There's two options on share screen. You can choose Dodi or Goetz.
Okay. So
Okay.
Yes, yes.
Got it. Okay, we see it now.
Okay. So this is just one case of many. It's a 58-year-old man, of course, the usual symptoms, and this is the fistula. So you can see the usual thing where you don't see the inferior petrosal sinuses, but you see a very nice superior ophthalmic vein. We agree on that, yes. And the fistula is probably very on the posterior part of the cavernous sinus, almost closer to the midline. So of course you could use a venous access, which is the superior ophthalmic vein, the fascial vein, and so on. Or you could do what we have seen in these presentations, go up on an inferior petrosal sinus, which is not visible. Or why not an arterial access? As we said, it's risky to go into the arteries that are going into the cranial base because of the risk of giving cranial nerve deficits. But some time ago, we found the possibility of going into this, which is a network of arteries going through the clival bone. So we are inside the bone here. And the access is, if you can see my arrow, is not from, it's from the pharyngeal artery, not from the meningeal branch of the pharyngeal artery, but from the pharyngeal branch of the pharyngeal arteries, the one that goes to the throat, more or less, to the nose. And so we are outside the skull. And from here, you get access, like here, to this artery, which, as you can see, goes to the fistula. And we call this artery of Guglielmo Pero because Guglielmo Pero is a colleague of ours that works with us. And he was the first one to recognize this artery and the possibility to reach the cavernous sinus from there. We are outside the skull again. We are not in the dura. And Pero in Italian means pear, and Guglielmo is William, so it's probably the William Spear artery, this one. And you can see it from both sides. The artery is midline usually, and anterior to the bone. And you see that by injecting from here, this is fill injected from here, it will go up and fill the whole part of the sinus, which is where the fistula is. We had also some reflux, but here we are in the pharynx. As you can see, we are in the throat. And again, of course, afterwards, there is a complete occlusion of the fistula. But where did the liquid embolic go? So if you go and look at the CT scan, you can see that the liquid embolic, it's really in the bone. And it comes to the cavernous sinus, which is really the medial part of the cavernous sinus, or the intercavernous sinus at the top. I show you one last case from William Pierce's collection, which again, it's the ascending pharyngeal artery, and we are in the throat here. We are not in the skull. And you can see sometimes these arteries are very well visible. And by injecting down here, outside the skull, you can reach, all the network and this part of the cavernous sinus, occluding completely the fistula from outside. And you can see where the onyx in this case is. It's in the middle of the ethmoid, and then of course it goes into the cavernous sinus there. So if sometimes you could look at this possibility if you cannot find any other way of reaching the sinus, and we think that the risk of giving problems to the cranial nerves in this case is really, really minimal. So that's what I wanted to show you.
Dodi?
Yeah.
I mean, the Clive Miguel commented, is that the artery through the foramen lastrum? It's not. As you showed on the CT, it goes right through the clivus. But we know that there's what we call it the carotid branch of the ascending pharyngeal. We know that that location is very close to a pretty dangerous connection, right? Dangerous, whatever. But we know that there's a branch from the carotid, from the ascending pharyngeal, that can join the carotid through the connection with the ILT and so forth. What do you think about it? I mean, that's excellent. I mean, you show that cases, but there's a very, very close anatomical relationship there with something that is pretty risky.
And Marco is asking the same question. I mean, basically for the bigger group, there are two things you want to think about. One is the cranial nerves, which a lot of the neighboring branches are supplying. So that's the one risk, right? And the other risk is arterial to arterial anastomosis that, like whatever Timur Goetz, all of us mentioned. So these are the two things to consider.
Yeah, of course, you must be aware of these connections. You must know them. You must know that that could happen. But again, we are not on the surface of the clivus. We are inside the bone. And that's much distant, meaning anatomically, even sometimes millimeters are very far away for some structures compared to the possibility of having this kind of refluxes. But we know arteries are everywhere, like veins, which are everywhere. So you must always be aware that wherever you inject something, you can get into something else. So liquid embolics are a little bit more dangerous than just placing coils inside the sinus. Just to let you know that there is this possibility, and sometimes it's very easy because you just get there, you inject, and it's done in a few minutes. So if you don't have a better solution to your fistula, just remember this possibility, which is not the usual possibility of going to meningeal arteries, because the meningeal arteries are the ones that will give you the cranial nerves deficits. Stay in the bone, and that's more safer.
Thank you. Kiripong, you had a comment about
about the same as Ethan. Yeah, thanks for showing the case, and hi, Bindorf and Timo. Nice to see you. Yeah, there are connections. As you always say, arteries are everywhere. And it is exactly the position that we can have the branches, the other transosseous branches also from the other systems, like the pteriovaginal artery, which has connections to the feeding artery of the ICA, and also to the MHT. So you can get connections to the ICA. You probably know what you're doing, but this should not be the case that you take into consideration in whenever you see a cavernous sinus case, because you saw someone has done it. Okay.
Yeah, as usual. Now, with whatever we're discussing, you have to know your limits. But again, I think we did something like 15 to 20 cases, and that was a possible solution in most of these cases. So yeah, just to know that it's something else that probably it's not well known, and so that's why I just wanted to show it, to let people know that there is also this.
Whoever comes to Val d'Isère knows. No, but I just want to, my congratulations. I mean, those are excellent cases, no question. But I mean, you also know that you are an extremely experienced operator. It's certainly not something to recommend for junior people. I don't think so. The other thing, to me, even if you, well beyond the dangerous anastomosis, and you showed that one case had quite a bit of reflux. I must tell you, the last dural fistula I treated 10 days ago, I used fill. I couldn't see the reflux. I couldn't see the reflux. So that makes it actually really tricky to embolize safely, especially if you have, in that area, you have a lot of skull base superimposition, so you don't see so well the anastomosis. The second case you showed, you had a lot of clival arteries also coming. So I personally, again, I think these are great cases, and it's good to know what else you can do, but I think it's a non-insignificant risk that you take if you do that. But thank you, Dolly. Good seeing you anyways.
Okay. All right. Any other comments? Kitty Pong has a couple of cases. I know it's 10 o'clock, and I'm sure whoever obviously needs to go. If any of our guest faculty need to go, again, we really want to thank you. It was a great session, and a lot of super rich material. More to talk about. We will have, I mean, for the group, we're gonna keep going like every 2 weeks we don't have any plans of stopping at the moment. So there'll be like a schedule of lectures for the year. But before we finish up with the veins, I think we're gonna come back and we're gonna have more. There's just so much in here, so much material from every perspective. So we're gonna have more on cavernous sinus, other veins. We can discuss more about these different approaches. Kitty Pong, do you want to show a couple of things if everybody's still around?
What I think is, it's going to be just like an add-on for the previous speakers, just a few pictures. Shouldn't take more than 15 minutes. Is that okay?
Thank you. Yes,
absolutely. Share my screen. Yeah. Can you see my screen?
Yes. Yes.
It's okay. So Bendorf was talking about your position, the catheter position when you do the phlebography for visualizing this area. Like for this case, the lowest one I've seen so far, the connection of the IPS to the internal jugular vein is, so this is the C1, C2, so it's been about between C2 and C3, so it can be very low as this case. So if you have the tip of catheter way up near the jugular bulb, you might not be able to catch the entrance to this,
I totally
thing.
The case that we published some years ago, and I think in 2001, about the Abberant, so-called Abberant sinus, Abberant IPS, where we treated CC fistula. It was a direct fistula, as far as I remember. That was also much lower. I was talking now about the typical range. If I don't, I always place the catheter if I don't see much, a little bit lower than. But what you're talking about is a so-called deep termination of the IPS, or what we call it Abberant IPS. And I have seen actually 3 or 4 more cases where this IPS comes way down. And then the jugular injection doesn't help you much, that's for sure. So you have to use oblique road maps from the arterial side to actually see that one and find it. It's not easy to get in. That's my experience. Yeah.
Yeah, thank you for the comment. Yeah, so the first time I did the injection, I was too high up, so I came back down to see it was over there. Okay, some other tips I probably need to share a little bit. Maybe we use different techniques, coils, larger wires, smaller wires. So many approaches, maybe arterial too. Okay, so we usually go through the IPS. So I read your book, Bendorf, the 2D venography to see the entrance of the IPS, but there are anatomical studies that say that the IPS has no connection, no direct connection to the internal jugular veins in up to 20%, which I don't think we are more successful than 80% of the cases. Okay, so this one I've shown you, very low. Bendorf called this Abberant IPS entrance. So what do I usually do? So this is the exact imitation because I read your book. So what I started doing this after I read your book, but I actually went on to put this in 3D. Okay, so we did this 3D angiogram because it's sometimes difficult to see which is the real IPS because we, as you've seen, as you said, we only see a small notch sometimes, and we don't know which is the right notch. So I put this, and another trick that I have added on recently, maybe a few years ago. We do a slight compression while injecting into the veins, not to get the contrast coming down back to the heart, but rather to retrogradely fill the whole system. So this is what we usually do recently. So this is we did once without neck compression. We don't see a lot of the IPS reflux over there. We did it again with the compression. We see the notch over there more clearly. So this is so you can see it's really traveling inside the groove that Timo was saying, but the rest is occluded. That's why we cannot see the whole thing. We put this on the 3D roadmap, and it's quite easy to get over there. Okay, so this is one of the technique that we use. I will stop this one here. It's like a adapting your technique to like something like more on 3D. Something like that.
It's a great idea. Venous compression is a great idea.
So we feel more efficiently, I think.
Yeah.
Okay, and I come back a little bit. So we were talking about, somebody was asking about the intercondylar confluence, which has something to do with this area. So I put a few slides on that. So this is similar as the ones you've shown. We see a lot of things going up like that. So one might be the IPS. The anterior one is probably not the IPS. It's more posterior than the inferior petrosal clival vein. Okay. So again, on 3D, it's easier to see. You've shown one case too. But it would be a lot easier to appreciate this anatomy when you see it with the bone. Okay, so this is what we see from this posture view. You see the true IPS. This is not a case of the shunt. It's for venous sampling. So we see the inferior petrosal sinuses from posture view. But in contrast to that, we rotate this around like that. Okay, so we are observing the skull base from outside now, and we see another structure just running parallel to this, the intracranially located IPS. We usually call this one inferior petro-occipital vein. It is also called, as you've said, inferior petral clival vein. It's the same structure. So it's extracranial compared to the IPS, which is intracranial. They run parallel to one another, and they can have connections during their course. like through the bones. So it's something that's very similar to the IPS that you can see very well in this case. And there's another structure here running along with the carotid artery, internal carotid artery, which this one is probably better seen in this 3D. I mean, in this actual view. So you see this one is traveling extracranially. So this is inferior petroclival vein. You see another one coming here. This is the IPS. Okay. And they both go and join the cavernous sinus. And you can see another round thing over here. This is the what Ethan was describing as the venous plexus of Reitert. I don't know if the venous plexus of Reitert has any clinical significance. I've seen one case of a shunt occurring probably in this vein of Reitert. I think it was René Chapeau's case. He showed us that one to me, but I have never seen anything relevant clinically to this venous structure myself. Okay, that's just a few slides to show you. That's all I have. Mm-hmm.
I was just going to say that plexus is much more known to ENT surgeons than to us or neurosurgeons.
So how is it important to the ENT surgeons?
Well, because it's a buffer. It's a cushion, basically, for the internal carotid artery in the petrous canal. And it plays a role in some infections traveling along this canal. So I found out when I did the first 3D reconstruction, some of them you know from the book, and I initially didn't know what that is, what I was looking at. And when I looked and went through the books, I realized I found some old literature and also some more recent in ENT papers, actually. It is quite well described. And it doesn't play maybe a big role for us, but for ENT surgeon, it does. Or at least some role, let's say, not a big role, but some role. I don't think it is suitable as an approach. I don't think you can, unless it's really very wide, but you have to imagine it's a small plexus within the, between the carotid wall and the bone and canal. So to maneuver a catheter through this to get into the cavernous sinus is quite difficult. And as you see, I think I showed this, maybe it was visible in one of the 3Ds I showed, it's a circumferential structure. It's not a tubular structure. So it's really just covering the carotid artery in a plexiform, like you have here in your illustration. So I don't think it is a suitable route to the cavernous sinus for us. That's what I would think.
Okay.
Pong.
Yeah.
Did the great images, and I like the idea of compressing the jugular vein to get better images even. Did you try with Valsalva?
No, never. Did you do that when you?
No, but I was thinking, listening to you, I was thinking if Valsalva may also, like, if you get a Valsalva, if the patient is intubated, you get a Valsalva while doing it, maybe you can have a similar effect.
That's possible, yeah. Good idea. Might try it next time.
No, I'll try first.
Okay, well, thank you. Thanks so much. Any other comments? Anything? Any questions? Let's see in the chat. Okay, I'm glad a lot of people enjoyed this. That's great.
Short comment, Ethan. I really liked it. One of the cases you showed with that connection from the supraorbital venous system. So if you look into some older papers from Madame Vigneault from the 60s or from the 70s, in those days they did something that was called orbital phlebography. And what they did is actually they put a tourniquet around the forehead and then injected contrast backwards into the supraorbital veins, then into the supraophthalmic veins, filling backwards the cavernous sinus.
look for Madame Venous. She used to work at Fondation Rothschild. Actually, she was the one training Jacques Moret, if that rings a bell.
That's
and in fact, to some degree, also Pierre, Max. Pierre was also trained by her in the very early days. There's some beautiful papers that she wrote.
Do you want to write in the chat her name so that we can?
Yes, I will.
Can look it up.
If I find out how to do that, I'll try. Okay.
Thank you. Thank you. I mean, there's so much more we could talk about. Cavernous Sinus, it's just an amazing, it's just a huge topic. I know there's so much in there. We kind of briefly touched on surgical aspects. There's a transorbital axis thing that we didn't really explore too much. The pluses and minuses of that. Arterial stuff. Thank you. Okay, good. Thank you. Okay, anything else? Again, thank you so much to all the lecturers, guest lecturers. Thank you. It's great. Yeah. Go ahead. Okay. As far as housekeeping, so we are in 2 weeks, we're going to have a session, I believe, in the internal cerebral vein. And then next week, again, we meet every Tuesday, 8 to 10. Next week is the virtual Embolic club. So we have like a whole, basically like Val Desire kind of style of Embolic club. You have cases, showcases. You can email on the webpage, on the BANANAZ webpage. You can see like, you know, it's easy. You just email me or neuroagent.org and let us know you have a case. We're going to record, so this session is going to be recorded, and hopefully we'll make it available soon to everybody. As far as the Embolic clubs, we're not really making available now for some because of some privacy considerations. It's in terms of timing, again, going forward, like the 8 to 10 a.m. Eastern time. There's no time that works great for everybody, but I'm going to try to see how we can best accommodate the timing as hopefully things, as more and more people, you know, can go back to work in some capacity. Any other questions? Anything else related to anything? If not, then again, thank you everybody for coming. Thank you for participating. And we'll see you next week.
Bye.
Thank you, Max. It was great. Great session. I really enjoyed it.
Thank you. Thank you. There's like, you know, whatever, like obviously spread the word. You can see like we have this room on Zoom for more people and more expertise. So like, obviously whoever wants to join, this is an educational forum that we believe is here to stay. The whole transition to online learning didn't happen under the best of circumstances for many of us, but I think it's a transition that's been long in coming. The technology is here. The interconnectedness of all of us is here, and I think that's just going to keep going.
Thank you very much, Maxime.
Thank you, Timo. Thank you so much. Thank you.
Thank you, everyone. Bye-bye.
Goodbye, everybody.
Bye, everybody. Thank you.
Bye.